it hurts to have to say that the standards of medicine for prevention of heart attack and stroke are basically very simple and based on cholesterol levels. If you have a low cholesterol level, they recommend a lifestyle, of course, but statins. And it's simple but wrong. Well, why do I say wrong? Half of people that have heart attacks and strokes have normal cholesterol levels. So not only does that hurt to have to say that, it kills people on a regular, every minute of every day. So what's even more unfortunate is that we know what else is going on. The science has shown us that the cause is cardiovascular inflammation. The science has also shown us how to treat and prevent cardiovascular inflammation. Now, regarding how to detect cardiovascular inflammation, I've done a full digital course on how to do it. It is simple. There's a simple series of tests, cardiovascular inflammation screening. You can get those. John and I developed a course, and that course is still free at this point. You can look on our website, look on the YouTube channel, and John can help you if you still can't find it. We've got plenty of videos on it. What's even more unfortunate, again, as I said, is that we know how to treat and prevent cardiovascular inflammation, the major cause of heart attack and stroke. Well, how do you treat it? Of course, number one is lifestyle. Obviously, decrease smoking. Get your weight where it needs to be. One of the key things about lifestyle that people do not understand is that insulin resistance, high insulin and high blood sugar are the most common cause of plaque in the arteries due to damaging the slick inner lining, the intima or endothelium of the artery. So that's one thing that a lot of this channel's about, helping people understand the specifics and the focus and the importance of high blood sugar. Now, there are people that control those things and still need help. And you can't get to this part of heart attack and stroke prevention without talking about drugs and statins. I know I get a lot of haters telling me that I'm paid by the big pharma. The answer, no, I'm not. I'm not paid by big pharma. I'm paid by my patients to help them not have a heart attack and stroke. So if patients do have the cardiovascular inflammation process going on, they do have plaque, I do recommend statins. Now, there are a lot of patients that are at the level of sophistication that understand that some statins are better than others for helping treat cardiovascular inflammation. That's exactly right. When you look at our discussion channels, look up Elbert Kwong, E-L-B-E-R-T, K-O-N-G. He's making some comments about that. Matt Kelly is as well. And I see that John Lorscheider, as usual, is doing a great job in terms of helping them through this. Some of the questions are, hey, Doc, I'm on Lipitor. I wanted to switch to rosuvastatin because I heard it was better for cardiovascular inflammation. I actually brought it up with my doc, and he's skeptical. Do you have any research, any science, any articles that show that? And the answer is, yes, I do. That's what this video is about. Actually, because John talked about the Jupiter study, Jupiter was the classic study showing that not only does inflammation cause heart attacks and strokes, that statins, and specifically rosuvastatin, does help decrease. It actually takes a major chunk out of the heart attack and stroke risk that you have from cardiovascular inflammation. So let's go to this study and talk about differences in statins and a couple of other things, how the statins work. This is 2017. That Jupiter study that we'll talk about later was in the New England Journal back in 2008 because it was a major, should have been a major standards changer. It wasn't, and we can talk about that a little bit later as well. But again, let's go to this article. It was in Current Cardiology Reviews in 2017. The anti-inflammatory effects of statins on coronary artery disease, an updated review in the literature. In other words, there's two different ways of articles that might review literature. One is a lit review, like you see here. That is reviewing conclusions that have been seen in other studies on the topic. It's different from a meta-analysis, because with a meta-analysis you get deeper. You try to actually compare the data in one study to another and pool that data. You got to have a lot of similarities, a lot of ability to compare. Now, this is not a meta-analysis. This is just an updated review of the literature. But it gets into some very interesting things in this area of differentiating statins, and mostly the pleiotropic effects of statins. Now, what do I mean by pleiotropic effects? Pleo just means multiple, tropic means going after. So, when you hear the term pleiotropic effects of statins, here's what they're talking about. Everybody and their dog knows that statins lower cholesterol. But what was interesting and what they showed with Jupiter and some other studies that Paul Ridker at Harvard did was that statins actually help even if somebody has inflammation, but they don't have high cholesterol. That's that 50% of people that have heart attack and stroke but had normal cholesterol. Statins still help anyway, and some statins help more than others. And again, it's through that pleiotropic. They have another effect on something else. What is the other effect, and what is that something else? Well, let's talk about it. As you see on the highlighted area, their beneficial effect, apart from cholesterol reduction, lies in their pleiotropic properties. Emerging evidence, lab and clinical trials have pointed out the pivotal role of inflammation in initiation and exacerbation of atherosclerosis. To get a little bit more graphic, what happens most often is that it's either elevated insulin or elevated sugar causes damage to the intima, the endothelial, the slick lining of the artery. Once you get damage, it really doesn't matter so much what level your cholesterol value is. Cholesterol will seep through that damaged membrane and lodge in the artery wall. Once you get that, that's called plaque, by the way, once you get that plaque in the artery wall, then you get your own immune system. Immune cells start going through that damaged endothelial lining as well. They begin to attack, they release enzymes meant to absorb, digest the cholesterol. Those enzymes can cause a heart attack and clot, or they cause a clot. And so there you go. Now, let's go a couple more details on this. Introduction, then they talk about, again, those pleiotropic effects. The beneficial effects lie in their anti-inflammatory properties, which are exhibited by a reduction in the release of C-reactive peptide, chemokines, and chemokines. Kines means attract, so chemicals that attract, cytokines, cells that attract, again, immune system properties, and adhesion molecules. Those are molecules that are used by immune cells to attach or adhere to the damaged slick endothelial lining or intima of the artery wall. They also modulate T cell activities, in other words, immune cell activities. Furthermore, statins inhibit the transendothelial migration of leukocytes due to a decrease in expression of adhesion molecules, such as ICAM1. So they actually even know now the adhesion molecules that are being impacted and how the statins impact them. Lymphocyte function-associated antigen 1, monocyte chemotactic protein 1. Statins further prevent inflammation by inhibiting chemokine release and Th1 type chemokine receptors. So if that didn't get geeky enough for you, I'm sorry, because that might be about as geeky as we get for this video. The next statement, or the next page goes into Table 1, which is just a series of some of the studies they looked at, and studies that many of you have probably already heard about. Jupiter, which John mentioned in those comments. Prove It, TIMI, WASCOPS, that stands for West of Scotland trial, TNT, ideal trial. And these are all showing things like, look, in case you can't read that, we will move that over a little bit. And simvastatin reduced deaths and major coronary artery events. Rosuvastatin reduced the risk of coronary artery events. Atorvastatin reduced risk. Atorvastatin does work. It just doesn't work as effectively as pravastatin, simvastatin, and especially rosuvastatin, or pitavastatin, the new medication. And we'll talk about those again a little bit more a little bit later. Pravastatin reduced coronary events, atorvastatin, etc. I will leave this, the link to this article under the video, as I usually do. Now let's go and check and see some of the other highlighted information here. First comments on the pleiotropic effects were made after researchers had observed the overall use or benefits of the use of statins were larger than what one would expect based on decreasing decreasing LDL or cholesterol alone. Jupiter, in fact, was a study designed specifically to look at this. Paul Ridker, one of the major proponents of this concept of cardiovascular inflammation at Harvard, actually was the principal investigator for the Jupiter study. And basically what they did was they showed that these people that had normal cholesterol values but elevated CRP, C-reactive protein, if you gave them rosuvastatin or Crestor, you cut their heart attack and stroke risk in half. So much so that they had to stop the study early because they knew these people needed that treatment. What's unfortunate about that study, the Jupiter study, and we'll cover it a little bit more in detail in other videos, is that the medical community did not respond. We did not change our standards based on that. Anyhow, that's another video, another topic. Let's go back and talk a little bit more about anti-inflammatory effects. Now, I said I wasn't going to get more geeky in terms of biochemistry. I will just make a couple of other points here. Many of the pleiotropic effects are mediated by the inhibition of isoprenoids, which act as intracellular signaling. And again, you see translational modifications of proteins such as nuclear laminins, RAS, Rho, RAC, RAP. I frankly am not an expert on any of those, but again, I mention that just to get the point that at this point in time, 2017, 2018, and now 2019, it's becoming really clear how statins decrease cardiovascular inflammation. Now, in this next section, they go systematically through this. What is the evidence? How was it built? Here's section number 3 is anti-inflammatory impacts. Now, I will, again, this is probably repetitive unless you're just way at a deep level, and I'm going to jump over this next couple of sections. Furthermore, statins have shown to decrease number of inflammatory cells in atherosclerotic plaques. Apart from the 37% reduction of CRP in the Jupiter trial, a significant reduction in incidence of major cardiovascular events occurred. Furthermore, other studies have revealed CRP adversely affects the endothelial function by reducing the expression of nitric oxide in cultivated endothelial cells. In other words, we're also beginning to realize that once you get that elevated CRP, C-reactive protein, that C-reactive protein appears to be part of the mechanism for damaging that lining of the artery. CRP has been used to predict heart attack and stroke death, and has been used effectively to do that. Unfortunately, it's still not a part of the standards of medicine. I use it. That's one of the key parts of this channel, this YouTube channel, to make other people aware. Preclinical evidence of statins and their effect. Again, more studies, more looking at reduced inflammation within the lesion, anti-inflammatory activity. That first one was for pitavastatin. The next three were simvastatin. The next two actually had to do with inflammation within lung tissue. It's a different issue. Now, pardon me, those of you who wanted to bottom line it and get straight to the issue about which statins have better power for cardiovascular inflammation. Here's where that is. It's over on the left-hand side, the yellow stuff that I have, the yellow highlighting that I've provided. However, it seems that not all statins have the same effect on inflammation. Nakagami and associates examined whether different statins exert differing effects on inflammation, insulin resistance, and the progression of carotid atherosclerosis in patients with dyslipidemia. As far as the inflammatory markers are concerned, pitavastatin caused a greater reduction in levels of TNF, tissue necrotic factor, MCP, TNF, and some others, compared to atorvastatin. So pitavastatin does help. It's a great medication. 2 years ago, I had patients that were starting on it. Unfortunately, at that time, I had to tell them, we don't know yet. Now we do know. It is very good at decreasing inflammation. But pitavastatin, or Livalo, I still don't use a lot. And let me tell you why. It's incredibly expensive. The best that you can do with GoodRx is to get it down to about $300 per month from its normal average retail price of $350. It's a great medication. It doesn't increase insulin resistance like most of the other statins, but it is very expensive. I don't use it. I use Crestor. If you manage your lifestyle well, manage your insulin resistance, watch the carbs, keep your blood sugar down, you can do well with very inexpensive statins. Again, simvastatin, pravastatin are great. I tend to use rosuvastatin for the most part. It has less of effect on insulin resistance, and you can go in very, very low doses. I have a lot of patients that are on 2.5 of Crestor twice a week. I personally, that's actually what I'm taking, 2.5 milligrams of Crestor twice a week. Now, again, back to this study, the author suggested that treatment with pitavastatin may be more beneficial than atorvastatin for reducing inflammation in patients with dyslipidemia. Similarly, Karuna and associates compared the anti-inflammatory effects of atorvastatin or Lipitor, and rosuvastatin or Crestor in patients with acute coronary syndrome. They found that even though both statins lowered the CRP level, the use of rosuvastatin was more effective in terms of events. So again, there you have it. There's science out there, and you know, if your doc wants, he or she and I can go look up at these studies and actually decide how much, you know, how geeky we want to get on that and how much we want to debate that issue. But the bottom line is, to me, the problem is not so much debating with docs which statin to use. The problem is getting docs and patients to understand that it's cardiovascular inflammation. It's not cholesterol level unless you have familial hypercholesterolemia. And once you get sophisticated enough to look at cardiovascular inflammation, we're talking about insulin resistance here more than anything else. And yes, priorities number 1, 2, and 3 for insulin resistance are lifestyle, lifestyle, and lifestyle. But there are still people that need other help, medications after that. Thank you for your interest.